Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ipsen.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information.
This program is presented by Medscape Education Global.
Hello, I'm Lorenzo D'Antiga. I'm a pediatric hepatologist working in Bergamo, Italy. Welcome to this activity entitled The Evolving Diagnostic and Management Landscape for Progressive Familial Intrahepatic Cholestasis, or PFIC. I'm really delighted to be joined by two friends and colleagues today. Valerie McLean, pediatric hepatologist from Geneva, Switzerland, and Jesus Quintero Bernabeu, pediatric hepatologist from Barcelona, Spain. In the next 30 minutes or so, we will discuss the diagnosis and management of progressive familial intrahepatic cholestasis. Additionally, we will try to highlight the reasons behind specific treatment choices, comment on guideline recommendations, and share our expert opinion. So let's get started. Before we dive into the clinical specifics, I want to address the big picture. PFIC is a group of rare genetic disorders that affect hepatocytes and cause abnormal bile composition and flow. However, different genes may cause similar problems. The overall incidence, if we take them all together in the PFIC group, is between 1 to 50,000 to 1 to 100,000 births, therefore quite rare diseases. The PFIC nomenclature has evolved over time. In the past, we were naming these diseases numbering PFIC1, PFIC2 and PFIC3, but now the modern nomenclature considers the gene and the defective protein. So far, a dozen of different PFICs have been described with different genes causing mutations and giving that picture. But we will focus on the three commonest conditions. PFIC1, currently named PFIC1 deficiency, PFIC2 or BSEP deficiency, PFIC3 or MDR3 deficiency. When a child presents to our clinic, the clinical picture usually looks like a young child, newborn or infant, who may have pruritus, jaundice, poor growth, and some degree of liver disease. Each type of PFIC can look different, though. In some types, only the liver is affected, in some types, while others can affect other parts of the body, so they can be expressed extrahepatically. When the liver is affected, different types of PFIC causes different type of injury to the liver cells, affecting different steps of bile formation and flow. If we focus on the three commonest subtypes of PFIC, we will see that they have a different clinical presentation. PFIC1 deficiency, or PFIC1, and present with liver disease, but also with some extrahepatic features. There is almost invariably an intestinal involvement. These patients have diarrhea and steatorrhea. There might be pancreatitis, usually later after the liver presentation. and the ear can be affected as well with hearing loss. BSEP deficiency or PFIC2 is actually confined to the liver. This protein is expressed only in the liver, and it presents mainly with a cholestatic picture, sometimes already with cirrhosis. And it is important to know that this patient may develop hepatocellular carcinoma. MDR3 deficiency or PFIC3 is a condition again confined to the liver. So the main signs and symptoms are related to liver disease with cholestasis, cirrhosis, and in this condition, it is not uncommon to also have the formation of gallstones, especially in adult life, when the presentation is later in life. So cholelithiasis is common. It can be isolated. And in this condition, besides hepatocellular carcinoma, there can be also the development of cholangiocarcinoma. But let's go into the management of these conditions. Jesus, shall we start from the diagnostic journey of patients with PFIC?
So, Lorenzo, you know very well that historically these patients have been diagnosed using the family history, using the lab tests, using the histology. But nowadays that everything changed, and the cornerstone of the diagnosis is the genetic testing. However, it's important to not overlook that the family history is very important, and we need to ask for that because that can give us some very, very important diagnostic clues. If there is intrahepatic cholestasis of pregnancy, if there is gallstones with other risk factors, if there is frequent pruritus, even if there is liver transplantation in patients with idiopathic cirrhotic liver disease, that give us the clue that we are behind disease, which is in fact an inherited disease. It is very important to highlight also that there are patients that present, let's say, atypical clinical presentation. So when we are asking for the family history, it's very important to understand that this family history is not limited only to the very well-described Mendelian autosomic recessive inheritance patterns, but also to cover, when we are trying to look for the family history, to cover also these more difficult atypical PFIC types.
What is the typical presentation in children?
You explained very well that PFIC, in fact, is not a single disorder. There are a lot of different disorders that are under the umbrella of the name of PFIC. Depending on the gene that is affected, the clinical presentation can be different. Even if the patient has more severe in some specific genes affected, the severity of the variant can also explain the phenotype of the patient. If you try to be simple, in an easy way, we can divide the patient into big groups. One is the group of patients that present jaundice and itching, and the other one is the patient that present fibrosis. So usually the patients that present itching and present jaundice are patients that present the clinical phenotype, the clinical presentation very early in life, the first months of life. And usually pruritus is the most bothersome complication that the patient and the family need to face. The pruritus not only affect the quality of life of the patient in all the spheres of the quality of life, the emotional well-being, the quality of sleep, but also the family quality of life.
Yeah. So let's say that at pediatric age, the most common presentation is neonatal jaundice, neonatal cholestasis,
Yes.
isn't it?
Yes. But there is also the other type of clinical presentation, which is the fibrosis. The patient with fibrosis are patients that also can present pruritus, even severe pruritus. But there are a lot of patients with moderate pruritus or mild pruritus that can present fibrosis and can progress and present the clinical presentation is mainly dominated by the portal hypertension and complications of portal hypertension.
Would you say that the severity of pruritus can help, guessing which diseases we are facing? I mean, different conditions may have different degree, the severity of pruritus.
For sure, the severity of the pruritus in patients with BSEP deficiency or FIC1 deficiency usually it's higher. There are patients with MDR3 deficiency that also have pruritus, but usually it's milder. The pruritus, and the phenotype is dominated by the complication of portal hypertension. But following this clinical presentation, hepatic liver-related presentation, there is also other extrahepatic manifestation, you highlighted before that depending of the type of gene variant or the gene that is affected, you can also present other extrahepatic clinical manifestation. For instance, in patients with FIC1, they can have hearing loss, pancreatitis, growth failure, diarrhea. In patients with V5B, they can have diarrhea, TGIP2, hearing loss, and so on.
So the clinical picture is still important because the extrahepatic manifestation, severity of pruritus can, be more specific, can help us in making the diagnosis or suspect.
Absolutely, it's very important. We are still physicians, so we need to ask for what is happening to our patient.
And what about biochemical tests? Are there tests that can help us?
Yes, it can help us a lot because we said that you have two different clinical presentations. One is the patient with itching and jaundice, and the other one is the patient with more fibrosis. So the patient with itching and jaundice usually have a cholestatic picture with very high bilirubin levels, SBA levels, but low gamma GT because the problem is in the hepatocyte that have problems to secrete the bile acids to the biliary tree. But the liver tree or the biliary tree is healthy. The problem is when you have a cholangiopathy. Patients with fibrosis usually are related to cholangiopathies, have a cholangiocyte disease, and that's why the GGT, the gamma GT, is higher in that type of patient.
So the biochemical part can also help us. Gamma GT is commonly low or normal in these patients, but a few subtypes have increased gamma GT. So as you were saying,
that can split the population into yes.
That's helpful. I think so. The clinical evaluation is still important. What about imaging?
Imaging is very specific and can help us, but not very much, I say. You can rule out other diseases, biliary atresia, when you are facing a patient with neonatal cholestasis. That is very important to not forget that this patient needs to be diagnosed usually using images also. We can use also to diagnose complications of the disease, of port hypertension, of hepatocellular carcinoma, but no more than that, I must say.
Yeah. And what about histology? We've been relying on histology for a long time. We still like histology in our patients.
We are pathologists. We love histology. I mean, otherwise we are not. We should be surgeons. So histology, it's very beautiful, but it's inspecific. We can have multinuclear giant cells, but we can also see that in other cholestatic liver diseases of the infancy, we can have proliferation of bile ducts and fibrosis, periportal fibrosis in the ABCB4 deficiency, in MDF3 deficiency, but it's in specific. We can also have cholestasis with not a lot of inflammation in patients with BSEP or FIC1 deficiency, but again, in a specific. One thing that can help us a little bit more is immunochemistry. In a special situation, TGIP2 deficiency, BSEP deficiency, MDF3 deficiency, we have immunochemistry, and we can ask for that.
Let's think about a patient with neonatal cholestasis. Let me ask Valerie, when would you do, or whether you would or not do a biopsy in a child with neonatal cholestasis?
So I think there's different approaches to the child with neonatal cholestasis. Some centers will use liver biopsy to rule out biliary atresia, which of course is the emergent diagnosis to be excluded in infants, while others who may have to wait, and I know that Jesus will get to this later with sequencing, but if in centers where you have to wait for molecular diagnosis, liver biopsy could be useful.
Definitely. So now you touched on the genetic testing. So Jesus, now next generation sequencing is a fundamental tool, but how would you use it in the clinical setting? There are different types of strategies if you want. How would you use genetic testing these days?
Historically, how we define these diseases is trying to look for a group of patients that are very homogeneous. And then when we have these patients, and that is not only related to PFIC, it's related to the rare diseases, we try to look for which genes can explain the phenotype. So that make us the approach that initially we make a clinical diagnosis and then with a confirmation, genetical confirmation of the diagnosis. And we use the genetic testing asking gene by gene with the Tanger. That is not longer useful right now. What we are doing now is that we have a phenotype of patient with cholestasis, fibrosis, liver disease, and we ask for NGS technique, a panel, an exon, even a genome in your center. And that give us the possibility to know that this homogeneous group of patients with very typical presentation, clinical presentation, can be explained not only for these 3 genes that we described at the beginning, but also for a lot of more comprehensive number of genes. And also these genes can also be related to different types of clinical presentations. Even there are patients that have heterozygous variants in the genes that can be not free of disease.
That's kind of actually complicated the picture, because now with this tool, which is very powerful, we can find also unexpected findings. For instance, carriers having some disease. But the strategy, I think different centers have different strategies using this very powerful tool that can sequence the whole genome in one night or in a few hours. So for instance, in your center, do you use the targeted approach, the exome sequencing?
We use the exome sequencing, and then the genetics is from a panel of genes, but we have the raw data. So in the case that we need, we can evaluate all the exome, but not the genome.
Yeah. What about in your center?
I would say it's the same approach, but they really do give the report just for the selected cholestasis panel.
Yeah. Even in my center, given the fact that the cost of sequencing is the same, whether you sequence only a few genes with this technique or the whole genome, we actually are sequencing the whole genome. But as you were saying, we tend to look at virtual panels focusing on the diseases that have been associated with PFIC. Great. So I think we've come to several good information in the diagnostic workup of PFIC. And now I would like to ask you, Valerie, about the management, the treatment. So in terms of treatment options, what do we have? What would you name from, the first line to the second and third line of options to treat patients with
So I think, like you both highlighted, pruritus is often the main symptom and really requiring relief in the children. So pruritus management is the first focus of our management. The classic first-line treatment is UDCA, so ursodeoxycholic acid. Then it really depends on availability in different countries. Historically, rifampicin has been used and still is in many places. And then, of course, now we have the advent of the IBAT inhibitors, so maralixabat and odevixibat, which are increasingly taking up room in the management of these patients. Now, which order they're introduced in usually depends on local availability and reimbursement schemes. The other key point of management, and again, this is in children of these patients, not just for the liver disease, but also to manage the extrahepatic manifestations, specifically the intestinal issues, is dietary support. So typically these patients have fat-soluble deficiencies, so we need to supplement them in fat-soluble vitamins. And ensure sufficient calories for growth, because often growth is stunted, and specifically in kids, we're going to enrich with MCT formulas. So those, I would say, are that's the mainstay of management.
Shall we spend a few words on interruption of the intrahepatic circulation? Because interrupting the intrahepatic circulation reduces the bile acid pools, so reduce the serum bile acid, and that is also associated with improvement of pruritus. What about this type of this strategy?
So, like you said, historically, the enterohepatic circulation was interrupted using surgical methods, and the 2 drugs that I alluded to, odevixibat and maralixabat, are the medical equivalent. In other words, they inhibit reabsorption of the bile acids in the terminal ileum, and so therefore deplete the bile acid pool. So those are the 2 tools we have to interrupt the enterohepatic circulation, especially focusing on pruritus. Then there's the bigger question of, do we have any tools to attenuate progression of liver disease? And that is a little bit more controversial, but we can move on to the discussion of when we do think we need to move forward with liver transplantation. And these are the patients whose pruritus is intractable despite medical management, despite surgical management. The patients, of course, who develop hepatocellular carcinoma. This is an opportunity to emphasize that following these patients for the development of hepatocellular carcinoma is essential, using serial AFP measurements or imaging like you discussed. And then another indication can be, of course, growth or portal hypertension and all the complications thereof. So first, those are the complications that these kids can present and the indications that would push us towards transplant.
If you had to suggest a schedule for the follow-up, how often would you test these patients, especially looking at these complications?
So I would say that depends on the type of PFIC. Certainly the BSCP deficiency patients are patients you're going to follow very closely because of the increased risk of hepatocellular carcinoma. So typically in our center, we would see them every 3 to 6 months with serial AFPs.
Jesus, would you have a similar schedule for these patients in your
Yes.
center?
We follow the patient depending on the type of variant that they have and the severity of the liver disease. But especially for the hepatocellular carcinoma, we perform an ultrasound every 6 months and alpha-fetoprotein also every 6 months. Yep.
Okay, I think we went through the management of PFIC, touching on the subtypes and how individualized should be the management according to the type of defect, so the gene involved rather than the group of PFICs. And we've given good information on the management. Still important to look at the patient, look at the clinical picture, but then use the diagnostic tools. So we have both the imaging, biochemistry, and next generation sequencing, and then some options that we have for the management, especially the management of pruritus, that in the past was probably the main indication to transplantation. Would you say we need to understand more, and what are the questions we would like to be answered in the near future on this disease, on the management, on indication to treat with different tools? What are the big questions in PFICs that are yet to be answered?
The first thing is that if with the enterohepatic circulation interruption, we are treating only the pruritus, or there is something else, we can change the evolution of the patients.
Definitely. We have to remember that these drugs are licensed for pruritus. And we know that pruritus is treated, but as you were saying, we don't know if that affects also progression of the disease.
For sure, we are changing the natural history of the disease because we are changing the pruritus. But what is happening with the fibrosis? It's also the fibrosis changing. That's one of the biggest questions. And the other thing is related to the genomics. So how we can improve the diagnostic of our patients using the genetic test that we have available right now.
Yeah. Would you agree, Val?
I would agree, and I would add that probably where we can also improve our understanding is in those patients that do need to go to liver transplant, how to monitor them for some disease-specific complications after transplant. And I'm specifically referring to PFIC1 deficiency and BSCP deficiency, but that's beyond the scope of today, I think, but still that's some fine-tuning is required there.
So I think now we can try to bring together all the information and also somehow compare our views with the guidelines that have been recently published by the European Association for the Study of the Liver. Let's see what the guidelines say. The guidelines are based on strong evidence, and let's see, maybe we can also comment a little bit on that. So the EASL has made recommendation on genetic cholestasis and has focused on the three main PFIC subtypes we've been talking about, FIC1 deficiency, BSEP deficiency, and MDR3 deficiency. And the first statement is on FIC1 deficiency, and the focus here is on medical and surgical management before and after transplantation, because we know that unfortunately this disease is associated with a new disease, a new liver disease in the graft, in the transplanted graft after transplant. So the question is, does medical surgical interruption of the intrahepatic circulation in patients with FIC1 deficiency prolong native liver survival and prevent diarrhea and steatohepatitis after liver transplant? And recommendation is that surgical interruption of the intrahepatic circulation, therefore we're talking about surgery, so biliary diversion done surgically, is not recommended as a routine treatment to prolong native liver survival for patients with FIC1 deficiency. And the second recommendation says that medical or surgical interruption of the intrahepatic circulation, so we're talking about both IBAT inhibitors and surgery at transplantation or post-transplant, could be used to treat diarrhea and steatohepatitis in patients with FIC1 deficiency. So the recommendation points at preventing the new FIC1 associated disease after transplant. It suggests that some type of intrahepatic circulation interruption can be useful. Diarrhea is an important symptom because we know that diarrhea after transplant is strictly linked to this new disease, development of this new disease. For BSEP deficiency, PFIC2, focus is on pruritus. And the question is medical surgical interruption of the intrahepatic circulation in patients with BSEP deficiency superior to other treatments in preventing or decreasing pruritus? And the answer is, the recommendation is, surgical interruption of the intrahepatic circulation can be used to reduce pruritus in patients with responsive genotypes. So the focus, and we know that BSEP responds to treatment depending on the type of mutation. So the focus is on BSEP genotype. And before considering liver transplantation, it is recommended to use or to attempt to interrupt the intrahepatic circulation. Medical interruption should be considered to reduce pruritus, again, prior to transplantation. So the recommendation is on both medical or surgical, both options are considered. The second focus for BSEP deficiency is on hepatocellular carcinoma, because we know that this condition is quite prone to the development of hepatocellular carcinoma, especially in patients having truncating mutations, the most severe mutations. The PICO question says, does screening for hepatocellular carcinoma improve prognosis and long-term survival in patients with BSEP deficiency? And what is the optimal screening age, interval, and modality? We've been talking about that with Val. The recommendation is for patients with missense mutations, an hepatocellular carcinoma screening interval of 3 to 6 months is recommended based on expert opinion. I think we mentioned that exactly what we do in our centers. For patients with biallelic mutations, and hepatocellular carcinoma screening interval of 3 months is recommended. So in patients with truncating mutations, the most severe, the follow-up should be stricter. And the follow-up and the screening of HCC should be done every 3 months. Again, on BSEP, there are a few more recommendations on the importance of the genotypes. Does the predictive effect of mutations on BSEP protein function have consequences for the follow-up, screening, the treatment decisions in this condition, BSEP deficiency? And the question is followed by the recommendation that states that management, including follow-up, screening, and treatment, including interruption of the intrahepatic circulation, both medical and surgical, should be based on the existing evidence for specific genotypes. So patients with BSEP really behave differently depending on the different genotype. And the screening intervals for HCC monitoring should be based again on genotype. The last recommendation for BSEP of the ESA guidelines is on the effect of management on native liver survival. Can medical surgical interruption of the intrahepatic circulation in patients with BSEP deficiency prolong native liver survival compared to other treatments. And the recommendation is to prolong native liver survival, surgical interruption of the intrahepatic circulation should be considered. When due to the current lack of data, it is not yet possible to recommend medical rather than surgical interruption of the intrahepatic circulation to prolong native liver survival. I would like a comment from you on this second disease, on PFIC2 recommendations by the EASL. Val, how would you consider these recommendations? I mean, they are certainly based on evidence, and we certainly follow them.
Well, I think it's evolving, isn't it? We're at a crossroads, and the options of medical interruption of the intrahepatic circulation is surely a very useful, valuable option, often preferred by the patients to the surgical interruption, which of course has the stigma of a stoma. And then in terms of we're at a crossroads because we will see if eventually this is a therapeutic option to prolong native liver survival.
And it is the first time that interruption of the intrahepatic circulation enters a guideline, I would say, either medical or surgical.
Yeah.
So that's quite interesting. Let's see what are the recommendations for MDR3 deficiency. Here, it is very important the genotype to indicate UDCA treatment and for the response to UDCA. So does the MDR3 deficiency genotype affect management? The recommendation is in patients with biallelic MDR3 variants, genetics should be used to predict phenotype and response to UDCA therapy. We know that this condition can respond brilliantly to UDCA, but that depends again on genotype. The second recommendation is patients with non-pathogenic variants in ABCB4, which is the gene encoding for MDR3, should be offered follow-up for liver-related complications, including malignancy. And here, cholangiocarcinoma also enters as a possible complication in this condition. The second PICO question on MDR3 deficiency is, should patients with non-potentially damaging MDR3 deficiency gene variants be treated with ursodeoxycholic acid, UDCA, to prevent or decrease liver-related complications? The recommendation is UDCA treatment is recommended for those with at least one ABCB4 missense variant and a clinical phenotype. The second recommendation is that partial response to UDCA has been reported in patients carrying biallelic protein truncating mutations. So these patients tend not to respond to UDCA. And I would like Jesus to comment on MDR3 deficiency and the recommendations, what they focus on.
So I think the recommendations are quite clear and are related to the type of disease that we are facing. Is different the disease that we are facing when we are treating patients with BSEP deficiency, which the problem is in the transport of the bile salt from the hepatocyte to the biliary tree. And now we have a cholangiopathy in which the use of UDCA can change the conformation of the bile and can make this bile less toxic for the cholangiocyte. So I think that all of us, we agree that we can use UDCA very easily in this type of patients, but there are some patients that never respond to that.
Thank you very much. I think we have to come to the closing remarks. Today, we made an overview on the management of progressive familial intrahepatic cholestasis, PFIC, a group of liver diseases usually presenting in children, but sometimes also in adults. Given the heterogeneity of PFICs, we highlighted the importance of moving away from the old nomenclature to favor a modern gene-based classification and residual protein function, which impacts the response to treatment. We then discussed the relevance of the tools available nowadays for the diagnosis of PFIC And we commented on how medical and surgical interruption of the intrahepatic circulation has impacted quality of life and liver disease progression, along with all our, treatments that cholestatic patients require. We then reviewed the EASL guidelines on genetic cholestasis, and we commented and compared them with our clinical practice. Okay, we have to come to a close now. Thank you very much, Valerie. Thank you, Jesus, for
Thank you.
discussing today on
Lovely.
PFIC. And thank you for your attention. We hope you enjoyed this event, but please answer the questions that follow and complete the evaluation form.
This program was presented by Medscape Education Global.